I'm honored to have been asked to present. I'm probably going to walk around a little bit. I think the microphone's actually working better now. I'm going to just briefly tell you what I'm going to talk about. I'm going to talk about what it's like to live with multiple chronic conditions or multimorbidity. Both terms are used, and I'll explain what they mean and some differences in people's definitions in a little bit. I'm also going to talk about what it means to take care of people with multiple chronic conditions. So why do I think this is a critically important clinical challenge and research challenge? I'm hopefully going to very briefly convince you that this doesn't only matter for geriatricians. I actually think this is really relevant for everyone. Most of the time I'm going to talk about what we can do to better inform care for this population. And it's a little intimidating, I have to admit, to come and talk to this group of like the world's premier methodologists. But my hope is actually that I can tell you about the work that we've been doing and some, I think, innovative ideas and methods that have been used. But what I really would love is to spur other people's interest in thinking about this issue. So this is one of my patients who was actually featured in an article in the New York Times, and I honestly just love the picture of her because I think it really captures why I am a geriatrician. And the focus of the article was really about how much of our medical and research and public health enterprise is really focused on the single disease perspective. But what would it really mean to be trying to transform all of that to one that was recognizing that many patients have many? So as an example of the evidence base that is put in front of clinicians, I'm going to talk a little bit about clinical practice guidelines. I think they're just one tool, and obviously there's other sources. But the reason I actually became interested in this problem is that I trained in an internal medicine program that was very focused on, what is the evidence? You had to know the evidence and be prepared to talk about it in rounds in the morning. And then when I became a geriatrics fellow and was seeing patients in clinic, it became very obvious to me very quickly that sort of disease by disease approach was challenging, and I wondered whether or not it really applied to my patients. So if you can envision a 79-year-old woman with 5 common chronic conditions: hypertension, osteoporosis, osteoarthritis, COPD, and diabetes. In 2004, we went to the clinical practice guidelines from major national and international organizations, and we basically looked to see what the treatment regimen that would be recommended for this patient looked like. And this is what it turns out to look like. There are 12 different medicines in 19 doses a day, and there's methods of assessing how complicated a regimen is, and this is pretty complicated. And then in these 3 columns are non-pharmacologic things that are part of the treatment regimen, either at specific times in this column or that are supposed to be integrated all day long. And then here's the recommended healthcare utilization for a patient based on what's in the guidelines. And it may not look like it, but we actually tried to make this regimen as simple as possible, using once-a-day medicines whenever we could, also trying to choose generic medicines and avoid drug interactions. And I'm not a PowerPoint expert, so keep that in mind. But the first time I tried to get the entire treatment regimen on a single piece of paper, essentially on a PowerPoint slide, it took me an entire day to basically get it all fit on one piece of paper. And I think that speaks to what we're potentially asking people to do, and how might it actually fit in with their lives. In 2005, even with Medicare Part D, if this patient was at or above 150% of the federal poverty level, just the medication part of this would cost the patient out of pocket $4,000 per year. So also a significant cost associated with it. And we know that most people are not actually taking this. For every additional medicine we give older adults, the odds of non-adherence increase by 0.16. And more than 40% of these are unfortunately very old studies, but more than 40% of older adults are not taking correctly a significant number of their medicines. So my question as a clinician is how do I, and I think really the fundamental question that I'm trying to answer with many colleagues, many from this group, is how do I, in an evidence-based way, decide which of these things on the list are actually most important for this patient? So how would I choose? I had one patient who told me that she would take 3 medicines that I could pick. She didn't care, but that I only got 3. Whereas other patients have a stronger opinion and really want to weigh in more about what the outcomes are, but equally would potentially like to be streamlining this and making choices. I don't think the way we make choices should be purely by virtue of sort of intermittent or not planned non-adherence. This is a slide that was actually created by the mother of a child with special needs that I heard presented at a PCORI conference about a year ago on what is the context of living with multiple chronic conditions for people's lives. And she created this and calls it a care map, and it's actually being studied currently. But her son is in the middle here, surrounded by the family, and then basically this is everything that she's essentially asked to navigate and coordinate. And I think for me, the thing that was really telling about this is she talked about how she showed this to her son's neurologist, and that the neurologist said, "Oh, maybe I don't need to see you in 2 months. Maybe I can have you come back in 4 months." Sort of like we don't always recognize everything else that people with multiple chronic conditions are doing, and perhaps we're not all the most important pieces. So then, as part of this project, we actually looked at a broader list of chronic conditions to basically see how well the clinical practice guidelines applied. And so we reviewed guidelines for 9 major chronic conditions in older adults, and we looked to see basically how well they actually would inform decisions. And basically what we found is while some of the guidelines at least mentioned older adults, they were all really very focused in their attention on single diseases. In the 300 full-page versions of the document, we find maybe 1 or 2 sentences about older people or people with multiple chronic conditions. There was really only one that actually reviewed the quality of evidence with these populations in mind. Most did address treatment of an index disease, so the focus of it, in the presence of single other conditions, but like to point out an adverse drug effect kind of thing, but none of them really sort of specifically gave guidance beyond those kinds of pairs. We also looked to see whether they addressed things that might be particularly relevant to with a patient-centered view of guidelines. So how often did they address how long you needed to treat someone in order to achieve whatever benefit was being reported? And it was limited in most of the guidelines. And then we looked at things like, to the degree that they talked about quality of life outcomes or functional outcomes. Did they talk about the trade-offs and goals of therapies? Did they tell clinicians how you might actually incorporate patient preferences and decisions? And did they talk about the potential burden of treatment and how patients might view that? So I think much like our hypothesis, when we looked through using the best we could find in terms of criteria to see whether the guidelines applied, that they really didn't. So that's what it's like thinking about the patient. These are 2 of my favorite papers. So what these 2 authors did, there's 2 separate papers, is they took a typical family physician's practice and this typical panel size and gave it the age and distribution and chronic diseases that you would expect if the practice was representative of the U.S. population. And then they basically went through the U.S. Preventive Services Task Force recommendations, and then the guidelines for the chronic diseases, and basically calculated how much time it would take the physicians to do all these things. And you can see that they would total, this assumes that the diseases are not all perfectly controlled. 17 hours a day just to do preventive services and do recommended chronic disease management. And so I'm always looking for an extra hour in the day, but this is staggering to me when just to think about. And one argument is, well, maybe it shouldn't be physicians doing all of these things, and I think that's probably true. I think a second piece is that we need to stop thinking that all of these things are equally important, and that we need to help providers and patients figure out which are the most important things to be doing that people are most likely to benefit from. Just to briefly talk about some data about the prevalence of multimorbidity. So there are different definitions of multimorbidity out there, and usually it's a very similar definition in the current literature to multiple chronic conditions, and that it's defined as 2 or more chronic conditions. I'll show you, though, that the prevalence actually varies dramatically depending on how many chronic conditions you consider. In this work that was done by led by my colleague Carlos Weiss, who was here and is now in Michigan. We looked at the NHANES data, and this is just focused on older women. And we actually, in this analysis, only looked at these 5 chronic diseases. So we did not look at all chronic diseases out there. And what the prevalence is that's reported here is the number of people with that chronic disease in NHANES that have that disease in isolation and don't have one of these 4 other things. And so you can see for all but one of these major chronic diseases, less than 20% of older women actually have the disease in isolation. And we did this also in younger patients and found not quite as high, but very similar numbers, that people 45 to 64 with one chronic disease typically have another. So I'll show you a little bit of more data about why this isn't only relevant for the elderly from actually a large array of studies. So this is work that compares a number of different international studies on the prevalence of multimorbidity. And there's 2 things that I want to take away from this. One is that you can see that the estimate of multimorbidity really varies very significantly. And a big piece of that is probably because some of these studies only used 10 chronic conditions and some of them use closer to 40. But the second piece is that in almost all of them, between the ages of 50 to 70, you can see a very striking increase in that prevalence. And when we think about pure population numbers, this population is actually more people than the older patients. So why might we want to look beyond just those 5 chronic diseases, that we had in our original study? And I think one reason is that they're definitely not the only thing that ends up affecting clinical management. I'm going to come back to this slide a little bit later, but when we think about how guideline developers might want to change, if they were willing to try to tackle this problem, how might they go about doing it? One of the things that we found is that there's some consensus that one of the pieces that should drive that is, well, what are the most common conditions? If the guideline is focused on an index condition, they might be able to prioritize really thinking about some number, but not infinite, of other chronic diseases. But how might they decide what they should be? And so this is again looking at NHANES data, but looking at people who are men and women who are 45 and older. And we were focused on people who had coronary heart disease. And what we did was, with a process of review with clinicians, we basically came up with the list of conditions, and not just diseases, that actually would affect the decision-making going into actually would you implement all the guideline recommendations. So essentially what makes decision-making more complex. And then we tried to operationalize those clinical conditions the best we could with what was available in NHANES. So over here you can see diseases. So probably not a surprise, 55% of people 45 and older have arthritis. This is a mixture of COPD and asthma at 25%, diabetes about 25%, history of stroke and 15%, and almost 30% have had a diagnosis of heart failure. So pretty striking prevalences of these major chronic diseases. But when we broaden it beyond just those diseases and think about things that might be multifactorial or caused by a number of diseases, but that actually affect whether you can implement the recommendations, there's really a striking prevalence of urinary incontinence, people who are dizzy or who are falling, which affects how easy it is to push people's blood pressure lower. This is how many people are on 5 or more medicines. 25% of people have mildly impaired renal function. And here is the 10% anemia. About 5% have evidence of abnormal liver function. 10% are on warfarin. And then over here, we looked at the prevalence of things that we thought might make implementing a treatment regimen or communicating about risks and benefits more complicated for patients. So cognitive impairment, mobility difficulty. This is the best measure of mental health function we had, a frequent mental distress. So that's probably grossly underreported. And then vision and hearing impairment. So living with multiple chronic conditions, we know it affects people's quality of life. It affects functional status. It affects people's ability to get a job and work, and it ends up altering life expectancy. We also know that this is the population that's getting care that is often fragmented, incomplete, inefficient, and there's concerns that it's not maximally effective. This population has much higher healthcare costs and utilization, but a big part of what really drives healthcare costs and utilizations is actually whether or not people have chronic conditions and any functional limitations or disability. So we can see that here, that of the top 5% Medicare spenders, the vast majority of them have multiple chronic conditions and functional limitations. So that when if we're thinking from like a health system design perspective, it's not everyone with 2 or more chronic conditions who is really interacting with the healthcare system a lot. That doesn't mean that the decisions for them are not complicated, but there is a subgroup that really are the people who are really being seen a lot. I feel like patient-centered care is a term that's heard a lot, especially recently, but I actually think that the research and the study behind it is actually quite thoughtful and actually dates many years back. One of my favorite pieces about this, and Maura Stewart has written a lot about this, is that patient-centered care might be most commonly understood for what it's not. Not technology-centered, not doctor-centered, hospital-centered, or disease-centered. And this is a cartoon from the New Yorker, which I thought captured this pretty well. I think that sometimes when we start to think about people not just in terms of their individual diseases, we might think about them where they are, and that I think in neither of these sides are we really thinking about the patient as a whole person. This definition of patient-centered care talks about that key elements are understanding what the patient's concerns are and their need for information, and that we want to integrate what we offer as clinical or health services with the person's world, and that it requires a common ground on issue and management, both between all of a person's providers, so making decisions about what things are most important, as well as common ground with the patient. And prevention and health promotion should be part of that, and that there should be some sort of ongoing relationship. This is just a little schematic that I think for me has been helpful about thinking about the fact that it's not very efficient to always be putting a different condition into this lot and thinking about it. And I think this every time I read a discharge summary from a complicated patient in the hospital, and there's this long list of 9 things that's like disease by disease by disease by disease, and it's hard to find something that tells you the overall picture. But that if we really want patient-centered care, we need to recognize that, first of all, that some of these things might not meet the criteria for being a disease, but that they end up overlapping with each other, perhaps in the way they evolve, but also in the way they're treated. So now I want to shift to this idea of how could we do this better? So when I think about this, when I'm seeing patients, what I'm trying to figure out is what therapies are most likely to benefit the person in front of me or people who are like them. And part of that is going to be variable, because if patients view outcomes differently, then whether or not something has net benefit is going to vary. But I also want to minimize the use of therapies that people are unlikely to benefit from or they're likely to be harmed from. And we know that when people are on that many medicines, that their chances of adverse drug events and interactions are astronomically higher. And I want to be able to do this in such a way that I am figuring out what matters to the person, and being able to communicate that. This is a schematic that was developed by Louise Walter, who is at UCSF, who has written a lot about making individualized decisions for cancer screening, but I think it applies conceptually to the management of chronic diseases as well. But the idea is that patient preferences and how they view the outcomes is essentially a movable fulcrum that is going to change how the likelihood of benefit balances against the likelihood of harm. And so that there may be times where we think patient preferences are so likely to be very similar that we can just know definitively that something is either more beneficial or more harmful, but that the number of decisions that are actually not in any way preference sensitive in people with multimorbidity, I actually think is quite small. So since doing this study where we reviewed the guidelines and looked at what happened to patients, I have been very focused on that I want to be able to go to clinic and have it be easier and more clear how to figure out what the right things for my patients are on. This work that I'm going to talk a little bit about has been very collaborative, and I'm only going to focus on these 3 pieces, and we'll talk about each of them briefly. But I think the goal of these 3 is to inform the way clinicians and patients and often families make decisions together, and that we know how to use that in an actual health system, that we know how to design our health systems so that we can actually support that kind of care. The reality is increasingly that recommendations and guidelines are being turned into performance measurement, which can be linked to payment and reimbursement. And so to some degree, I think this is the way that we are seeing evidence-based recommendations actually really influencing care. But I'm not going to talk about these 3 so much today, given this group's interest, but just in terms of thinking about how do I see these fitting into, kind of the whole picture. So we were funded now about 5 years ago by ARC to basically develop a preliminary framework that was stakeholder informed about how each stage of these 3 processes might better address people with multiple chronic conditions. And this was done in a collaborative way with a group from Tufts, including David Kent and Tom Tricolinos, who's now at Brown, and Katrin Uhlig, who has sat on many guideline panels. And then there was a group here at Hopkins as well. I'm just going to highlight some of these the pieces from this in hopes of spurring discussion. So the study design and analysis group was thinking about both trials and observational studies, and talked about that a fundamental question is whether the participants are representative of the actual population who have the disease, which hopefully I've convinced you that many of them actually have, many of the people in the actual population actually have multimorbidity. And just, in way of background, we sort of stumbled across this interesting fact that as the number of trials with explicit age exclusions has decreased, we have seen an increased enrollment of older patients, but I think it's no surprise that they're still well below the levels that older patients are affected. But I think the most interesting thing is over about the same period of time, I think there's been an increasing number of exclusions of people with multiple chronic conditions, with over half of heart failure trials excluding people with any renal problems or liver problems or anemia. And there may be very, very good reasons for it, but it just to me is interesting that I wonder even if older people are in the studies, I'm not sure that they're this population. And several people have written about the fact that the exclusion and inclusion criteria is less important than who is the average patient in the trial. Because I often see people asking or talking about, well, what the inclusion or exclusion criteria are, but obviously if there's one person who's 90 but the mean age is still 50, that's a judgment of the people reviewing the evidence, but it may not make the evidence actually apply. So David Kent has written about this idea that we could potentially avoid the problems of conventional subgroup analysis by using multivariate risk stratified analysis to compare treatment effect in patients across a fuller spectrum of baseline risk than the conventional one variable at a time subgroup analysis. And in the work from our grant that was actually just published in JGIM, they talk about how much bigger the sample size would need to be in order to be able to have been analyzing a treatment effect. And obviously that the studies potentially would become, astronomically big if you were trying to do multiple of those. I've talked a little bit already about heterogeneity of treatment effect, but I think one of the things that I've struggled with is figuring out whether my patients are actually at greater or lower risk of the outcome that a treatment is trying to prevent. So what's their variability in baseline risk, and can I predict that reasonably accurately? But that they also may have greater heterogeneity in competing risks that might make them, if there's a long time to benefit, that might make them less likely to achieve that other beneficial outcome. I know many people have written that there's been very few places where there's actually true variability in relative risk reduction. But I think there's also probably in the patients that we're thinking about pretty significant variability in the risk of harms. And we may be more likely to learn about that variability in risk and harms from observational studies that are longer and in more diverse populations than the original trials. So the question of whether pragmatic trials really are going to give us more generalizable information, I think it really comes down to whether or not the treatment effects are actually generalizable across all the patients enrolled. So we may not be able, we may not be able to draw conclusions about anyone if we don't have the appropriate analytic strategies. So now thinking about systematic reviews and meta-analysis, and this work was really heavily informed by Tom Tricolinos, who I know many of you know. So when we're thinking about can systematic reviews and meta-analyses better address this population, I think we have to recognize that whatever the limitations are of the primary studies are part of that. And so if we're not able to draw, so that may affect our ability to draw conclusions about people with multiple chronic conditions. but that if we really want to be addressing this population, that there may need to be focused and prioritized key questions about this group. And that it's possible that really wanting to address this population might actually change the way you view the trade-off between internal validity and generalizability. So with work done with Milo Puhan and Daniela Vollenweider, I was interested in the question of, could systematic reviews actually have drawn conclusions about people with multiple chronic conditions had they wanted to? So what we did is we went to the Cochrane reviews for 4 major chronic diseases: COPD, heart failure, stroke, and type 2 diabetes, and we ended up with 11 reviews. And we pulled all the studies that made it into those systematic reviews. So we didn't start with a de novo systematic review, and you could argue if you had a key question that was really focused on comorbidity in some way that you wouldn't want to be relying on existing systematic reviews. But we didn't actually have any funding for this project, so it seemed like a reasonable place to start. So of the 161 trials, only 70 of them described the prevalence of comorbidities in any table, and we looked at the main papers and any supplemental papers. So we went back to I probably didn't make it clear, we went back to the studies that made it into these 11 Cochrane reviews. The mean number of the trials that actually reported any comorbidities, the mean number that they reported was 3. And so there were 237 total comorbidities reported in these 70 trials. 19% of the comorbidities actually gave you a definition of the comorbidity and told you how it was that it was determined. So patient report was for 8% of comorbidities. A baseline exam was for 30%. Medical records were 3%, and other methods for 2%. And again, remember, this is out of those people who actually reported comorbidities. More than half of them did not report the data source for how they determined what the comorbidities were. And only 40 of them described whether the patients were receiving any treatments for the comorbidities. So then we were interested in basically whether or not the studies had looked to see whether there was potential for heterogeneity of treatment effect. So very few trials use the presence of a comorbidity as a subgroup variable to determine whether it is an effect modifier. In a related paper that Daniela led, actually showed that of all the subgroup analyses, very few of them were done according to established criteria, with only 5 for focusing on comorbidity. I didn't report that data, but probably they weren't done the way you would recommend. None of them used interaction terms to formally test for effect modification, and only 1 trial considered heterogeneity of treatment effect due to different baseline risks, and none considered the effect of competing risks. So this is just for the diabetes trials. I have similar slides for all the diseases, which I can show at the end if anyone's particularly interested in. But then we look to see whether the inclusion and exclusion criteria and what was excluded. And so of the diabetes trials, more than 40% of them excluded people with renal insufficiency, with liver insufficiency. Almost 40% of them excluded people who are on insulin. I think it's about 35% excluded people with coronary artery disease. This drives me crazy, this serious concomitant diseases. But you can see that 25% of them excluded people with that, and so on. And if you remember from the earlier slides, these are probably very extremely prevalent comorbidities in people with type 2 diabetes. I think there's 2 ways to interpret our work. One is that it would have been hard to say, I think, if you'd had a key question in those systematic review about people with comorbidity, that the evidence was as strong or of highest quality. But I think, though, that it shows that you can look for it, and it may be useful thinking about as the way we design and report trials in the future, but that it is possible to essentially look at systematic reviews and try to glean whether or not the quality of the evidence would be the same. So I'm just going to summarize this because you probably all understand, could speak much better about the biostatistics inherent in this than me. But Tom has written about the meta-regressions of aggregate data, giving the potential to draw erroneous conclusions, and so that we need novel methods for aggregate data meta-analysis and meta-regressions, or perhaps even better meta-analyses of individual participant data. But that if we had information about the joint distribution of benefits and harms, that we would potentially be able to do a better job than just in this first bullet. So this piece applies both to the systematic reviews and the guidelines piece. I'll talk about it here. But one of the key recommendations that came from this group was that as we're thinking about the PICO questions, that comorbidities should be considered, up front in the design of them, because you really need to specify the conditions of interest. And that you may want a formal question about whether or not there's effect modification. In terms of outcomes, thinking about comorbidity might actually change the outcomes that would get on the list, right? You would potentially be very interested in whether there were any non-disease specific outcomes like function or quality of life assessed, which are arguably of more universal relevance to people with multiple chronic conditions, so that they shouldn't all be disease specific outcomes. And recognizing that that's not recommended to use surrogate outcomes, but that they are used, but that thinking about this patient population, that the linkage between surrogate and clinical outcomes may actually be less tight, because the relationship between the treatment and the surrogate and the patient important outcome may actually be different in older patients or in people with multiple chronic conditions. And I think glycemic control is a perfect example of that, that in people with multiple comorbidities, it's not as clear that lowering it actually improves things that patients care about. So now I'm going to shift to clinical practice guideline development, which I have to say, having thrown darts at clinical practice guidelines in my first work, I was very nervous about trying to basically recruit guideline developers to this process. But I have to say, it's really been a very, very educational and informative, but also a true pleasure. And I think guideline developers really want to know what methods they can use to make their guidelines more useful to clinicians. And again, I think they're just one example of a tool for implementing evidence. So we developed recommendations for each of the steps of the guideline development process, and they're listed here. I'm just going to actually mention the recommendations that came from two of them. And this work was also just published in JGIM. There's 4 papers that were in the Journal of General and Internal Medicine this month. So getting back to what we talked to at the beginning, this idea of thinking about the prevalence of conditions and having that inform a priority setting process was really pretty much universally believed to be relevant, but that it wasn't the only piece. That whether or not there was the potential of an interaction between conditions or a condition and treatment or between treatments should also weigh in. So there are combinations of conditions that don't make decision-making more complex, and so that if, given limited resources, don't want to focus on them. There was not agreement whether or not people's preconceived ideas about whether or not there was actually any evidence should inform this process of essentially developing your key questions. And I don't think that's unique to the discussion of multimorbidity. But I'm not going to go through this again, but we actually did this project as a way of seeing whether you could get population representative data about the full spectrum of comorbidities that might make the decisions inherent in guideline recommendations more complicated. In thinking about guidelines and how they may transform themselves to be more relevant to people with multimorbidity, this is the traditional approach, and obviously guidelines have tried to address specific other pairs of comorbid conditions, but not to date with very much in the way of actual evidence reviews for those questions. But I don't think this framework is going to go away, because this is really the way a lot of our guidelines, not just in the U.S., are designed. But perhaps a process of priority setting would enable us to make sure we were doing this as well as we could and focusing on the most important questions. But it's possible that a guideline that still has a focus of an index condition or a risk of index condition, if it's focused on screening, might want to think about people with multimorbidity not from this sort of single variable at a time framework, but perhaps for something that is trying to account for people's overall morbidity or their overall risk. For example, it could be life expectancy, but it could be other things as well. There are a couple of examples of a guideline that has specifically chosen to focus on a pair of conditions so that it doesn't really have an index disease. But when we think about the heterogeneity of possible combinations and the limited resources for guidelines development, I think that this probably isn't going to be the only way we can try to tackle this. And a guideline that's focused on 3 conditions, if they were prevalent and had the potential for real interaction, it could be worthwhile, but we're not going to get a guideline for every possible combination. And then the fourth piece just is that the guideline could potentially move away. Guidelines could choose to deliberately not be focusing on diseases, but perhaps be focusing on something like the consequences of multimorbidity. So a guideline that reviewed all of the evidence about how we can reduce polypharmacy or reduce inappropriate medications that are sort of looking at the consequences of multimorbidity. I'm just going to jump to this one because the recommendations that came from this ARC grant are by no means give guideline developers all the answers. It was really meant to be a first step forward. But this is the piece where I think that what we're coming back to is I'm trying to prioritize what's the most important things for patients would be to understand the relative strength of the recommendations, and does that relative strength vary for any groups of people. And that the specific identification of people who are not likely to benefit or who are likely to be harmed would be very useful as I'm trying to decide what's most important for the individual in front of me, and that it's really a method of prioritizing recommendations. So there's a couple of guidelines that I think have done things that are related to this. So one of them is the ACCP's guideline for antithrombotics for AFib, and they compared risk prediction scores for stroke. And they also had an entire chapter devoted to patient preferences. They describe caveats to recommendations, but they don't give any specific recommendations for any subgroups. But they do identify people who are likely to be harmed. So these things were sort of coming out around the same time, and I definitely think if we went back and we reviewed guidelines today, that they would look differently than they did now almost 10 years ago. This is the ADA's guideline for diabetes, which I think it is great that they are specifically talking about older adults as a special population, and they note that these things all make it reasonable to have less intensive goals for glycemia, but they really don't give you any guidance about how to decide. And so yesterday Monday in clinic, I saw a lady who has AFib and on warfarin for GI bleed, warfarin for that, who was admitted to an outside hospital for rectal bleeding, which turned out to not be anything significant. And so she went home fairly quickly. But when she went home with, I counted them, 54 pages about how she should get her blood sugar lower. And she's in her 80s and she's got multiple chronic conditions. And it was just so striking to me that that still we've really not made the connection for how to actually do things. And the fact that, glycemic control is a performance standard, I think is probably a large part of the fact that they were focusing on discharge on her glycemic control. So this is work that was led by Sung and done with Milo and Tianjing, which I think also sort of is a look forward to what might we hope to see in guidelines. But what this is a framework for thinking about how we might actually have valid risk-stratified treatment recommendations and guidelines. And the pieces that are needed is a risk assessment tool to estimate outcome risk, and evidence about treatment effects on both benefits and harm outcomes. And that you can't forget that patient preferences are going to essentially affect the relative weight of these outcomes. But that this needs to be used to apply the evidence of treatment evidence to outcome risks, and that then the guideline developers should be doing a benefit harm assessment to define treatment thresholds according to outcome risks. So Sung and the rest of the group, we reviewed 133 guidelines on diabetes, heart disease, stroke, and cancer, and COPD. And of them, 20 of them make risk-stratified treatment recommendations. But for most of them, it was actually very unclear how they actually made the risk-stratified treatment recommendations. And so it is uncertain if these guidelines actually support patients and physicians in finding an acceptable benefit-harm balance that affects both the profile-specific outcome risks and patients' preferences. So is it possible to conduct benefit-harm assessments that could help us prioritize across conditions? So with funding from the ARC's Evidence-Based Practice Center and a methods project, and then an ICTR grant that Milo led, we used the Gale NCI method for benefit harm assessment, which was developed for breast cancer, but used it with data from evidence syntheses. So they had previously used all the data from the same study, and we were interested in whether or not this could help inform the process of looking at a body of evidence. So the approach combines data on treatment effects, baseline risks, and the relative importance of outcomes, and gives you a net benefit harm index to inform decision making. Obviously, an important piece is how much we know about the relative importance of outcomes may be often inadequate. So this is the results that came from the time that we used this for roflumilast for the treatment of COPD. Basically, a negative number means that the harms outweigh the benefits. And I'm, in the interest of space, I'm only showing you one of the analyses and just for women. But you can see that when we look at people when we're thinking about risk of moderate to severe COPD exacerbations, that the harms of roflumilast outweigh the benefits for almost everyone. And this holds true when we essentially do sensitivity analyses about the relative weights of all the outcomes. But when we look at just those patients who have a very high risk of having one or more severe COPD exacerbations, that there is a small group of people for whom the benefits and harms actually appear like it might be beneficial. So people who are at more than 20% risk of having a severe COPD exacerbation. And here is the data that shows basically the probability that the net benefit harm index is positive for patients at risk of severe COPD exacerbation. So it is possible to essentially get confidence bounds about these estimates. So I'm looking forward to discussion about other people's ideas about how we can better support this process of developing individualized decisions, to help me make this treatment regimen something that my patients actually can and want to do and that's going to help them achieve their goals. And I just want to end on this picture of my patient because, so someone told me that geriatricians have the greatest tolerance for uncertainty of any physicians and complexity, that we're like sort of drawn to it. And that may be true, and there's certainly, and I realize that both other clinicians and researchers may sort of be, shudder at the thought of all this, complexity. But, hand in hand with that complexity is really like the richness of people's life stories and their humanity. You don't get to 3 or 4 or 5 chronic conditions without having some really good stories to tell along the way. And that like sort of humanity, like to me, it's really a privilege to sit at that table, even though many times I wish I had better information to help people make decisions. I'll stop there. Yeah. Not many what? I'm sorry. Oh, ours. Mm-hmm. Yeah, I mean, I'm sure there's people in the room that could weigh in on that. I guess for me, one of the striking things is that the information about harms, because they obviously are greater in older people and in people who are on more medicines and have more conditions. The methods of doing comparative effectiveness studies and using propensity scores. I'd be interested in what other people think. I think that if they're done well, there's an argument to be said that, well, we shouldn't ignore the information about, we have all these people who are getting these drugs. We should figure out how we can learn as much as we can that's valid and then potentially use that to actually inform the studies that are really important to do. But I'd love to hear from other people about that. Oh, okay. Yeah. Yeah, so, I mean, I think I think it's hard to, I think there's 2 things there. One is that the way, I think there's lots of interesting things in what you said. I mean, one of it is that what you describe about why they want to do that, I think that is exactly the problem. And I think that many physicians actually are aware, maybe I spend more time with geriatricians than the other people, but are aware that the fact that like sometimes you just need to ignore the performance metric and stand up and say that you think they're awful or that they're going to hurt older people. So I don't think everybody would think that, but that pressure, I think, is very real. The issue of whether that person should have been, in the trial, or how would you enroll them, and to me, I guess that non-compliance because it makes them feel bad, I would think that should be counted as a harm, right? So that I am probably not an expert on how you use compliance in clinical trials appropriately, but if somebody's not taking it because they don't feel good, that should be reported as a harm. It should be measurable, and we should be able to add it to whatever system, we used one, but whatever system you use to calculate the benefit-harm balance. Yeah, I think they should be captured. I mean, that's how patients feel. It's a patient-important outcome. Uh-huh. Yes, I think so. There's no evidence that overall treatment regimen, putting that patient on all those medicines, that overall treatment regimen is benefit. And so I would agree that I think that's like I had a slide which I took out, which one of my fellows created, which I thought was so great. That was like 1 + 1 does not equal 2. We can't just add up 5 people's diseases and, the treatments for 5 diseases and say that's what the regimen is. We know that people are more likely to have harms. They're more likely to have interactions. And so the trick is figuring out which of those pieces are the right ones in the context of what other people have. But I think we know more than we think we do. I think that and that if we were more explicit about when we don't know something, it would be easier for that to not end up in a performance standard, right? So that it would leave it more to the clinical judgment, where that's not the provider saying, I'm going to give you the medicine anyway, it's your choice not to take it. That to me is that is exactly where we don't want to end up. But I think we actually know more than we think we do, because if we know that dizziness and feeling badly matters, then there should have been a way for that to have ended up translated all the way through this process to the performance standard, or the multiple pathway. Yeah.
Because I just don't get it. First of all, I think first of all, I think it's essentially helpful to the trialist that they have pragmatic.
Right.
Now there's a new bench heading for pragmatic trials, so we're saying there are clinical trials and there are pragmatic trials. And I'm not sure that having a pragmatic trial, we're just talking about multiple morbidities, I'm not sure it's actually pragmatic to take into account all these different drugs and multiple morbidities and so forth. Aren't we better off trying to look at the true situation and make that more the goal of our clinical trials rather than to make 2 warring factors? So I want you to convince me why we need these pragmatic.
Oh, I don't think I'm. I just don't get it. I had it up there in part because I think it's a term, because people say well, let's just get more older people, let's just get more people with multiple chronic conditions in all of the studies. I think I use it and was trying to convey that may not necessarily, if we don't do it right, we may not end up with information that actually informs the decisions that we're making. And I certainly, but that is the term that I hear people use about, well, let's just get them all in the study. And I guess I have the same reservation as you, that I don't know that splitting it and saying there are these over here and then there's regular trials over here. I would completely agree that I'm not sure we gain that much. Yeah. No, it's an interesting question. So I think it's I don't actually know all of the history. So I don't know that I'm going to be able to completely explain it. But I guess my point I was trying to make is that people talk about this, but I don't think that's going to totally solve the issue. Yeah.
So you discussed the medications with hospitals for more conditions, but do you work with diet also, or have dietitians who work with that, who consider the different conditions?
Yeah. So
there are issues like, I know, in trying to reduce blood pressure, we may give high potassium foods.
Yeah.
Some of those are high glucose, and glucose can go up.
So I didn't actually go into that in the interest of time, but one of the things that we did in this is we looked for interactions between medicines, and we looked for interactions between the non-pharmacologic treatment regimens. And while we didn't find a specific interaction for this patient with medicine, we actually did for the exercise recommendations. They actually partially conflict, which talk about confusing patients. But I can tell you from my own experience that there are patients who are like, what is there left to eat? There's not anything, there's really hardly any food left they can eat, and they may have limited, access to that not everybody has access to the same grocery stores or the same resources, and so I think it's a very real issue, and actually, so I don't know how many times those dietitian personnel or other people who are doing that are sort of aware of the potential conflict, because they may be coming from single disease disciplines as well. So my patient that got sent home with the 54 pages, I would say 35 pages of that was what she was supposed to eat and not eat. Yeah, I think that we need to be able to tell people what's actually the most important thing. And I don't know the answer. Is the most important thing that someone who has heart failure be low salt? Would we say that trumps everything else that might be on their list? I don't know that we know. I don't know that question has been asked. It seems to me that there's not total consensus about the value of a low salt diet. But currently patients are just given everything. So I think we have to figure out how to tell them what's really the most important pieces of it. Yeah, thank you for having me.